So again, welcome everybody. Hi, Traian from the US. Thanks for joining us. And so the plan today is to have another look about, let's say, the starting bricks that we are putting together to have models, lower the models of the flows inside let's say, aneurysms and in general vascular flows. So we'll have basically an introduction of the, let's say, clinical problems that are relevant for this kind of applications from Florian Bernard, who is a partner of ARIA. And then we will have more technical talks concerning, as I was saying, the building blocks of what we will be doing for lower the modeling. Of course, we are at the very beginning in this domain, and so let's say that this is a first step, and the discussion is open, of course, about what to do next, even though we have already plans to work with Umberto Morbiducci, Valentina Nazzi, and Caro Cao at the Politecnico, together with Ludovica Saccaro here and Florian Bernard in Bordeaux, and as a function of the advancement of the project with Simona Perotto in. So please, I think the first talk is from Florian, if I'm not wrong.
Yes, I think so.
Very good. So the podium is yours, Florian. Let us dream.
We'll try.
Okay, thanks.
So I'm sharing the screen. Can you see it? Yes, no?
Yes,
we do.
Thank you. So good afternoon, everyone. Good morning for those in the US. Thanks, Angelo, for the introduction. Yes, I'm co-founder of Nurea, which is a company here based in Bordeaux, where we develop software for medical image analysis, and our big focus is on cardiovascular diseases. And first of all, I mean, the first disease we addressed was abdominal aortic aneurysms. So this talk is really to present you the challenge we face and the different challenges physicians face in clinical routine, the impact on patients, and how we could improve, let's say, the decision process for the physicians, and at the end, if we dream, saving patients. So this presentation is really an introduction of these different issues and challenges, and I think we will go deeper into the technical aspects with the following presentations. Okay, so generally speaking, cardiovascular accidents is the first cause of death in the world. In the US, it represents one death every 36 seconds. In Europe, it's one death every 4 minutes. So it's huge. It's a huge problematic. And one of the reasons why we are not able to try to anticipate these accidents is that these diseases are asymptomatic, meaning that the patient has no symptoms until the accident. The exams to diagnose the presence of these diseases are quite complicated in the sense that it's a CT scan. It's not something that you can do easily. And the analysis and the interpretation of these scans are really time-consuming for physicians. So our goal, I would say, in the framework of that project, but also our goal as a company, is to help radiologists and surgeons in their clinical workflow, so helping them diagnose these diseases, helping them understand the evolution of the disease, and having like a prognostic of the risk of accidents. So the way to do that is first to provide some tools able to provide them with the standard of care. So really helping them extracting the clinical indicators they are used to have at their disposal to decide, but go further using, for example, biomarkers to help them stratifying the risk of accidents. And I think that's where biomechanics can play a role, and I will try to show you and explain you which role it can play and what needs to be done to use that in clinical routine.
Excuse me, Florian, to interrupt you. I forgot one important point. I'm very sorry. So if all agree to record these presentations, maybe Lynn, you can record it, please, because we have colleagues who mentioned that they would like to listen to the videos and to the presentations. Please let me know if anybody has constraints concerning the recording of the presentation. Sorry, Florian. Thanks.
No problem. So here I listed a few, let's say, major diseases that you can find on the vascular network, meaning aorta, peripheral arteries, carotids, and they're basically of two kinds and they have different names according to the anatomical zone where the disease is present. But let's say the first kind of disease is an enlargement of the vessels. That's what we call aneurysms. So you have aneurysms usually in the aorta, or at least I hope you don't have any aneurysm in the aorta, but you can find them usually in the aorta or in the brain. And the other kind of disease are stenosis. These are basically occlusions of the vessels due to plaques, calcifications, cholesterol, and so on. So that's the two main diseases that we will face. And diagnosing these diseases for physicians is quite challenging because it requires on a CT exam to do a lot of measurements of diameters, lengths, percentage of occlusion, and so on. And that's really time consuming. And with that, it is still difficult for them to understand the evolution and how risky it is for the patient. Okay, so let's have a look at what a physician is actually seeing when a patient comes to his office after having a CT. So that's a CT slice, so it's an axial slice. A CT image is made of several slices, with a different thickness. So that's where you first have some bias in the accuracy of the image. And on each of these slices, you need to measure, to find the arteries and measure where there is the disease to characterize how risky it is, or try to characterize how risky it is. So here it's a CT with contrast product. It's a really cardiovascular oriented exam. And what you can see in the center here is the aorta. In red, you have what we call the lumen, which is actually the circulating blood flow. And in green, it's the thrombus, which is not circulating blood flow. It's something else, which is darker in the image, harder to identify. And that's symptomatic of the presence of the disease. So imagine that you have thousands of slices like that, and on each slices you need to measure what are the diameters of these arteries, if there is calcification, thrombus, or if the artery is sound. So it's a really time-consuming job with a lot of bias. If the CT is not cardiovascular oriented, there is no contrast product. And here, as you can see, it's even more challenging to identify where are the arteries and take the measurements accurately. And here in red, that's the aorta. And on this kind of image, we cannot distinguish lumen and thrombus because everything appears exactly the same. So there is other diseases. We talk about aneurysms. Now you have examples of stenosis. You can see here in blue, for example, in the image in top right, you have the calcifications. Here it's the stenosis degree of 83%, meaning that the vessel, the carotid, which irrigates the brain, is occluded at 83%. And you have other examples in lower limbs, just to show you a global view of what a physician needs to see in the images. So to diagnose these diseases and decide if an intervention is needed, there are some guidelines which are based on the metrics we just talked about a few minutes ago. So diameters and stenosis degree. For aortic aneurysms, you have guidelines on the maximum diameter of the aorta. It is considered as an aneurysm if the diameter is larger than 3.5 centimeters. And we decide the intervention if the diameter is larger than 5 centimeters, 5.5 for men. However, the correlation with the actual risk of rupture of this aneurysm is not too good. Actually, there is 30% of ruptured aneurysm that happens before reaching this threshold of 5 centimeters. And conversely, there is 60% of aneurysms that will never rupture if the diameter is larger than 5 centimeters. So something more precise is needed, because that's a lot of useless intervention that are done, and patients that should have an intervention that are not qualified for intervention. And that's the same thing for carotid stenosis. And it's even worse because there is no consensus between the different countries. Carotid stenosis is considered to be followed if the stenosis degree is larger than 50%. But to decide the intervention, it's depending on countries. In France, we usually do the intervention if the stenosis degree is larger than 50% or 70% if there is a precedent event. But for example, in UK, they do not do the intervention if there is no previous stroke. And the reason for that is that all these thresholds have been established in the 90s with techniques of diagnostic that are no more used, like arteriography, where you put a catheter in the vessels, inject the contrast product, and try to evaluate the occlusion. Obviously, the insertion of the catheter will cause some detachment of plaques, and that can cause strokes. So everything needs to be thought again, and I think that's where biomechanical indicators can play a role. So first, just another example, if we push further this morphological analysis, you can just compare two different geometries and see how it evolves. That's the first criteria that is not used currently in clinical routine, but it tells you where, how the vessels are deformating, how they are deformating, where the aneurysm is growing, and that's obviously a criteria to decide if the evolution is at risk or not. So can biomechanics be the solution? I think at least it will be part of the solution. There are several papers now that you will probably heard about in the next talks on aortic aneurysm, showing that wall shear stress could be a good indicator for rupture risk. Wall deformation, as we've just seen, are also a good indicator for the risk. And simulating the blood flow could also provide us a lot of information on the formation of thrombus and if the aneurysm will grow or if it will continue to grow. The same thing stands for carotid stenosis. There is other indicators, biomechanical indicators that we could use. For example, pressure drop after the lesion. And that's well-known indicators, for example, for coronaries. to decide if the intervention is needed or not. Flow velocity and recirculation is another good indicator, and also interaction between the flow and the plaque to try to understand if detachment are possible and what would be the impact of the detachment of plaques. So what needs to be solved? We talk about biomechanical indicators that could be interesting and that could help physicians, but if you want to really implement that into the clinical workflow of the physician, you first need to have data to prove that your model, your numerical models, are able to help physicians to predict the risk of events. And to do that, you need a lot of patients, ideally thousands of patients with several exams to show that you are able to have some kind of anticipation of the outcome. And that's really hard to get from real life. So that's the first step. And the second step is that from the CT exam, you need to first extract the geometry, reconstruct, have a 3D reconstruction of the arteries to do your numerical simulations. So that's the part we are actually, at least Nurea is providing a tool to do that automatically. And that will allow to do that on maybe not thousands of patients, but at least hundreds of patients. There is a different clinical study showing that the different parameters could be correlated to the risk for the patients. But it's so time consuming and so complicated for now to extract these geometries from clinical data that the studies are reduced to just 10, 20, maybe 50 patients. But that's still not enough to prove any relevance of these criteria. The third part is to design numerical models and find the correct hypothesis for the numerical simulations. What would be the boundary conditions? Should we consider that the thrombus is actually fluid, or should we consider that it's completely solid? So where are from the numerical simulation, where are the actual walls of the vessels? And then once we'll have the results of the numerical simulations, we will try to correlate them to the risks for the patients, so to the outcomes that we know from the initial clinical data, and find new risk stratification. So the goal here is really to provide some kind of indicators to the physician to say, okay, here, I don't think this patient is really at risk, even if the diameter of the aneurysm is quite high. And conversely, maybe on this patient, the tortuosity of the arteries, the wall shear stress is too high on some specific location. And this patient needs to undergo surgery because the aneurysm is really at risk. Once we'll get there, if we want to implement that in a full clinical workflow, we need to consider that a physician has no knowledge about how to set up a numerical simulation, what data should be provided as input. So everything should be automated and should be able to provide a result in a few minutes. And I think that's where reduced order model can play a role to accelerate the numerical simulations that we will have done on a specific database. And once we'll have that, we can imagine to put this tool in the hands of the physicians, help them anticipating the outcomes for the patient, the risk, better classify patients that are candidate for surgery and the ones that are not, and reduce these cardiovascular accidents. So I think now it's time to go into more details on the different works that have been done in the framework of this project. And I thank you for your attention. And if you have any questions, I'll be pleased to answer.
Thanks a lot, Florian. Please, if there are questions, either in the chat or in the directly to Florian. I see there is anybody there.
Angelo,
Tommaso.
yeah, I actually have a question. So first of all, very nice talk. I have like, so it's a kind of a naive question, but if you go to the slide where you have like the whole workflow, so basically from geometry, modeling, and then indicators. Do you have an idea about, let's say, some kind of a forward uncertainty quantification analysis, meaning how much the uncertainty in the geometry impacts your computation of indicator, how much the choice of the boundary condition impacts the. So my question is, what is the dominating uncertainty in your opinion?
Yeah, that's a very good question. So if we take just the geometrical indicators as an example, the uncertainty, even between manual measurements by different physicians or even by the same physician but at different time points, the difference is quite huge. On an aneurysm that is 5 centimeter large, you can have 5 millimeter difference between 2 measurements by 2 physicians. So it's huge. So obviously you have a first uncertainty that is there. So it's very, very hard to have an accurate description of the geometry. So obviously if then you add numerical simulations, boundary conditions, modeling of the wall and of the rigidity of the wall, I have actually no idea of the impact on the final results. But that's part of the challenge. I mean, even if you have some model doing that, how would you be able to validate that in real conditions? So you have some in silico models where you can try to reproduce the flow and the fluid structure interactions. But how can we make sure that what we are doing in this context will be still valid on a real patient that you cannot open and check what would be the mechanical parameters? But I think in the following talks, and maybe Umberto will and his team can answer that question better than me.
Thanks.
Okay, thanks. Umberto, you want to please?
Okay. This is a very. It's hard to answer to this question for several reasons. Indeed, there are more extensive studies evaluating the uncertainty, the budget of uncertainty associated with simulations, patient-specific simulations. I am more confident on what have been done on the carotid bifurcation, for example, and the budget of uncertainty is given by several contributions, going from the blood rheology, inflow and outflow boundary conditions, the mechanical properties of the wall. If you have plaques, the mechanical properties of the plaques, so plaque composition, and blah, blah, blah. So what happened at the beginning of this century was that, for example, the group of David Steinman has demonstrated that the budget of the most contribution to uncertainty was given by geometry reconstruction, but for the carotid bifurcation. But at the moment, the automatic procedures that have been introduced has substantially minimized the uncertainty related to the geometry reconstruction. But I'm talking about carotid bifurcation. I have no idea about abdominal aneurysms, also because we also have the contribution of the presence of intraluminal thrombus that make things harder. So this is a question I have no idea at the moment. I know that the budget of uncertainty has several contributions that, and this is another problem, pile up not linearly. So it's difficult to evaluate the overall uncertainty, what we can do, and it's also hard to validate because we don't have the golden standard. An in vitro model is not the golden standard, and in vivo data are not the golden standard because the images are convolution of reality. So I have no idea about this. What we can do is to standardize a procedure, and everybody used a standardized procedure so we can compare the results, and we can give the results a value that can be given to share with a vascular surgeon or a physician.
Yes, thanks, Umberto. Indeed, maybe one approach could be to use standard tools of uncertainty quantification, and once one has, as Umberto say, the part of uncertainty coming from, for example, geometry, one can answer, say, to the pressure. So what is the degree of fiability of the pressure drop as a function of the degree of fiability of say, the geometry? That's kind of answer that one maybe could try to give. And with lowered models, just to come back to the subject, this can be done like with Monte Carlo approaches or without, let's say, refined tools. We have maybe another couple of minutes if there are other questions coming up.
Oh, Angelo, let me add one more thing, sorry.
Please.
What we can do is to discuss with the physician and try to understand if the budget of uncertainty has a clinical meaning or not. Okay, if you evaluate a pressure drop 7 millimeters of mercury plus or minus 3 millimeters of mercury, 4 millimeters of mercury is okay for the physicians, is okay also for us.
Sure.
This is what we can do.
Sure. Yes.
Yeah, that can be complicated if we are talking about wall shear stress, for example, because they have basically no idea what it is. So
in terms of wall shear stress, you need to standardize the way everybody calculate wall shear stress. This is the only way. So it's not the real wall shear stress, but the shear value of the wall shear stress.
Great. Thanks for these contributions.